So I will introduce Dr. Heewon Kang, who's a research assistant professor at Seoul National University in South Korea and an honorary senior research fellow at the University of Queensland School of Public Health. Her research focuses on evaluating support for and developing strategies for tobacco endgame policies in the South Korean context. And so Heewon's going to present some work that she did with us while she was visiting us for a year. And I'll now hand over to Heewon. Thank you.
Sorry, I'm really unorganized at the moment due to some unexpected sequence changes. Yeah. But anyways, thank you for the introduction, Coral. I was going to say that I'll be following the discussions made by Josh and Holly on reducing the availability of tobacco products, but seems like I'll be the first to discuss this measure. Before starting the presentation, I would like to acknowledge the traditional owners of the land and pay my respect to the elders past, present, and emerging. Also, the study and the authors were supported by institutions such as the NHMRC, but we declare no competing interests. Okay, so limiting the sales to pharmacies. I remember that last year here at the symposium, I thought Janet was here, but Janet said, oh, there you go. Yeah, hello. Janet said, if you talk to people in the US about this measure, they would say something like, are you out of your tree? But it's actually a viable endgame measure. It not only reduces the availability of tobacco products very much and enhances control over sales, it provides a great opportunity to provide a cessation support for those purchasing tobacco products. There have been a number of previous attempts regarding this policy. So the first was a bill in Iceland led by an MP who was also a former health minister, and it included a 10-year plan to reduce retailer licenses, raise license fees, and to end sales in all other stores, so the pharmacies would be the only place allowed to sell tobacco products. So the first two attempts faced severe criticism, including from the people in the tobacco control community, because they considered back then in 2011 that conventional measures would be adequate in making progress. The third attempt received less attention and also failed. There was another attempt in Oregon in the United States. This bill was led by the chair of the healthcare committee, and he proposed to classify all nicotine-containing products as Schedule III controlled substance. So although all these attempts failed, discussions on this important measure has continued. So we aim to identify the policy's potential impacts and implementation processes and to provide recommendations for policy and future research. A framework we used for analyzing these policies included 2 axes and 6 dimensions, including effectiveness, equity, and acceptability. So 8 databases were searched for relevant literature, and because we aim to identify articles to limit the sales of tobacco products to pharmacies, we excluded articles discussing limiting sales of e-cigarettes and NRTs. There was no restriction on publication dates or study designs, and the data extracted were narratively synthesized using the policy framework that I have provided previously. So after screening, 18 studies were included. So 16 of these addressed limiting the sales of cigarettes into pharmacy settings. And most of these evidence were from Aotearoa, New Zealand. Most of the evidence were non-empirical, with only 5 empirical studies. 4 assessed the potential reduction in retailers after the policy adoption, and one assessed public support. So these are the findings. In terms of the effectiveness, the studies report that limiting the sales of tobacco products to pharmacies would reduce the number of tobacco retailers by at least 80%, leading to a reduced smoking prevalence and further to health gains. Also, some unintended effects were reported. These included increased safety issues and workloads for pharmacists. And these people also noted the potential normalization of smoking due to selling tobacco products in a health promotion setting. Few studies assessed equity, and they reported that there are higher density of pharmacies in areas with higher socioeconomic status, urban areas, and lower proportions of Black, Hispanic, and Latino residents. Also, the studies reported that costs will be increased for people residing in areas with lower pharmacy densities and who are unable to quit. These are the findings on implementation. There was only one study from New Zealand addressing the cost for this measure, and it concluded that the healthcare cost savings due to this measure would far outweigh the cost required for the legislative implementation and cessation program costs. Regarding feasibility, it aligned well with other public health programs led by pharmacists, such as dispensing methadones and clean needle programs, but it also conflicted with efforts to end tobacco sales in pharmacies. Some practical issues were raised, including from pharmacists, including time, staffing, and space constraint. However, pharmacists also reported that the feasibility of this measure would increase with reduced smoking prevalence. There were a few more studies on acceptability dimension, and the experts and people who smoke considered this option as an effective policy to reduce availability and smoking initiation. However, the support was quite modest among pharmacists in New Zealand, with only 26% reporting that they are likely to participate in this program. Also, potential moral conflicts from pharmacists and clinicians from dispensing and prescribing tobacco were raised. So where to now? These studies that we covered propose some conditions that could help adopt and implement this policy. And the most frequently noted one was a tobacco retailer licensing. It would help evaluate the policy's effectiveness and also reduce the number of retailers during the transition period. Also, it was noted that it would be better suited to implement this policy in a country with an endgame goal and as a part of a broader supply reduction strategy, as this would address the issues raised by the pharmacists. Also, it was crucial to involve pharmacists from the initial stages of discussion. Regarding the research implications, because most of the evidence here came from countries with high income and low smoking prevalence, additional evidence from settings with different environments would be required. Also, there were limited evidence on cost and unintended effects, so that will be also required. And even in the dimensions such as effectiveness that was most addressed in the study, there are further research areas to explore, such as estimating the indirect impact due to reduced environmental cues and social norm shifts. Equity lens for all dimensions would be required. I'll just pass on this conclusion as this is just a summary of what I've just said, but I would like to stress out again that pharmacy-only tobacco supply is different in a way that it limits the supply, it limits the product availability while enhancing cessation support. This is to acknowledge my wonderful co-authors, Janet, Catherine, Wayne, and Coral. And thank you.
So Heewon.
Really interesting. I wonder if in the pharmacy supply model, you would probably have to have the products behind the counter, so they can only be provided in the same way that currently retail places in many countries. Was that an explicit part of the description that the pharmacies would have to be retrofitted to be able to provide an extra space for the dispensing of tobacco products?
So in our SRO implication and things to consider, having it under the counter was considered as an important factor, but I think more research like practical considerations would be required to where to actually keep the tobacco products and where the pharmacists can actually supply the products to the consumers. Yeah.
And CINAHL, you had a question?
Thank you for a very interesting presentation. You mentioned the pharmacy deserts under equity. So yeah, towns where there's one pharmacy or no pharmacies. How would you potentially overcome that?
I think one of the tricky part of this measure is that unlike most of other retailer reduction strategies where the density decrease is a little lower in areas with low socioeconomic status. Because as I've said in my results section, there are more pharmacies in the higher socioeconomic areas, it becomes quite conflicting. Well, I think it would be a good thing if everyone living in the low socioeconomic status areas could all quit, but that's very unlikely. So I guess there would be an additional cessation support required for them, but the extent and the means to deliver cessation support for them is an area of further research.
Over here, Natalie.
So I got into tobacco control about 2005, and I went to America first time to one of the conferences for SRNT, and it was the first time I ever saw tobacco sold in a pharmacy. It was deeply uncomfortable. Pharmacies to me are a place of health, and yet they were selling or making available the most dangerous product out there. It made no sense to me, and it seemed irrational. That's just my personal feeling about it. So I feel that the unintended consequences, how do you articulate this to people is the part that needs the most work, because it kind of goes against everything. It seems very counterintuitive to me, maybe not to everyone else. So my, one study, me. Do you feel that that's where the biggest gap in the knowledge was when you did this review?
It was in fact one of the major issues raised by the reviewers of this paper. I think it's important to note that it does align with some of the public health programs led by pharmacists, including methadons and the clean needle exchange programs, which is also providing some, well.
But that's reduced harm. Methadone's reduced harm. The needle exchange is reduced harm. This is not reduced harm.
I think Janet will be able to respond.
Thank you very much. I think Natalie's right that it's really important to frame this intervention appropriately. And when we did some in-depth work with pharmacists, if they appreciate the idea that this would be a short-term measure and that it would be accompanied by advice to support people to stop smoking, then it changes it from a commercial orientation to a health promoting one. And I think that is quite congruent with how they see their role. So, but I agree, it's an important message.
Would you thank Heewon?